We move to any other comment from the audience? Okay, we get trained. As we get trained, the technology advances and new things come into play, and we should incorporate them into the proper way. Bill.
Evangelos, thank you so much for 2 wonderful days. I feel quite exhausted by trying to understand what everybody else has said, and I will try to rush through my talk because you must all be very tired. But it has been wonderful, and your warm welcome, much appreciated. I come from there, of course, originally, Basingstoke in England, and recently we just have to tell you that we have celebrated 2,000 complete cytoreductions for peritoneal malignancies in Basingstoke, most of them done by Brendan Moran, who sends his regards to you all and his best wishes. I'm proud of what the people have done since I moved into one of the education offices in the Pelican Cancer Foundation. I think inside the mesorectal fascia, we've pretty much agreed in the last 2 days we do an operation. Isn't that a very simple thing to take home? You've just got to learn to do it properly. And that's not all that easy. But when you talk about metastases, death, and more complicated things outside the mesorectal fascia, it gets very much more complicated. This is my new, as it were, retirement part-time home. I'm chairman of the Colorectal Cancer Project in this beautiful place on the mouth of the Tejo River in Lisbon, in Portugal. Wonderful joy to walk in through the front door in the morning. How nice to be surrounded by such beautiful things. The idea of calling it the Institute for the Unknown is that it is exactly where Vasco da Gama set out and Bartholomew Diaz to discover India and Africa and most of the world. And the woman who is our boss, Leonor Bellezza, she wants us to do that with colorectal cancer. So we do our level best to do that from this wonderful place. The patient's garden was, you got very briefly there, indoor patient's garden. But we also have wonderful technology, and that's what I have to talk about in this talk. We have the European Academy of Robotic Colorectal Surgery, which was dreamt up really by Amjad Parve, Professor Parve. We've got scientists hovering over us on the 3rd floor, hundreds of them, doing radiomics. We've got a wonderful expert in immunotherapy from Sweden. But the things I've encouraged and perhaps initiated are the excellent CRT chemoradiotherapy response surveillance. These are things listed there. Dynamic imaging, of course, I know nothing about, but we do have a very nice head of imaging who's just come down from Belgium. In surgery, well, it's Amjad Parve. I'm an ancient voyeur. I sit watching him operate, and I think I would say only one thing perhaps has changed about the objective of TME that needs to change, possibly, is that we should perhaps be within the 2 septa. It's not intrafascial, it's extrafascial, that word should be, but within Denonvillier's septum at the front and Valdea's septum at the back. And I will just say a little more about that, because I love surgery, and I'd much rather talk about surgery than the other things. But this is the sort of case that I take special joy in watching Amjad doing, and I will just show you 1 or 2 of the new feelings of actually seeing the TME operation, which I dreamt up all those years ago, done even better than I think we could do it open. But only because the surgeon is very good, is still a surgical business, a surgical challenge. And I see the future of the robot as being really important because it perhaps can be turned into numbers. That, I think, is that Valdea's septum coming down from above, and it shows that plane inside, which is even completely safe, unlike the plane outside, which from above is not safe, from below can be lethal. This is from below transanal, and I'll actually stop that for a moment because I'd like you all in the audience to think. You are looking up through this is a TATME, a transanal TME, and the video I think we were near to seeing yesterday with a beautiful presentation by an English young surgeon. But what is the matter with that TME coming from below? And the answer is, there is one too many layers on the mesorectum. And let's carry on with the video. You'll see exactly what I mean. I don't really like that instrument so much. I prefer monopolar diathermy and traction and counter-traction. What is the clue? We are seeing bone, bare bone. We're one layer too far out. And the correct layer is inside. What I call Valdea, we can think of various names for it, but it's terribly important to understand it. And using this slightly crude method, I think, but we are finding the proper plane. And you see there, between the two, that's the dangerous outside one, and that is the reason, one of the reasons, the big reason people get lost in transanal TME is that they get into this outer layer. And look what a real layer it is, too. I think that video given to me by Greg and Ralph from Colchester is one of the most important videos to do with modern TATME. The white layer is because we're outside Valdea, and we must, I think perhaps my name for that layer might perhaps be the sacromesorectal septum. It's an extra layer at the back, which is continuous with the lateral pelvic sidewall fascia, and the mesorectum, with its rectum inside and its cancer inside, hopefully, lies like a sailor inside a hammock, with his head going down into the anal canal, of course. We've still got anastomotic leakage, and what on earth have I got to say about that? Well, it's defeated me all my life, but I do think I just ask you to watch where my thumb is there, and there. I think the old test, which we call the Brendan Moran test of the squirting blood, and of course now you can have a much more expensive endocyanin green test, which I like, of course, but you can still do old-fashioned tests if you haven't got the endocyanin green. You might think about my little stent. And interestingly, Basingstoke still uses them by the dozen, and so do one or two places where my registrars have gone. Little soft silastic stent for propping open the closed anal canal. We have to rush along. Anyway, if you want to buy them, write to Diana via Pelican. What about planning? I'm not going to stop there for any time because I don't really, I'm prepared to be guided by the clinical oncologists and the medical oncologists and other people. We've talked about these things. Liquid biopsy could change everything, couldn't it? As I say, we've got scientists everywhere, but I'd much rather talk about functional results and how perhaps we can improve them and how we can improve lots of things. That was a German revolution in Berlin against the awful results, the loss that we've heard so much about in the last few days. And sexual function, really important. So I'd like just a few more minutes, I hope I have, to talk about real advances in better radiotherapy and the complete response. A personal view, which I'm not really entitled to, especially not in the presence of Rob Glyn-Jones, who's done such a wonderful job the last 2 days. But Lars Pollmann and Bengt, I gave 2 Lars Pollmann memorial lectures. Gosh, how we miss him in these meetings. We all love Lars, a lovely man. And he was the guy who, when he did his thesis as a young man, he went off to Moscow, where he found this guy, and Alexander Pavlov, another one, who had done the physics and gave us really 5 times 5. And I'm watching Rapido very carefully, because I want to know whether short course and a wait and chemo during the wait is not in fact much the best buy. And if you want a little early in the race for which is better, the established chemoradiotherapy or short course followed by chemo, just look at Buchko's study, in which the overalls, although there wasn't much difference in the oncological outcomes, there was nearly 10% difference in the number of people alive. And I think that's very encouraging. And I'll skip that one because it's a bit long, but just taking out a sentence. I'm sharing it with you, he says in a personal letter, the notion that 5 times 5 is actually better. You know, Christoph is probably the leading radiotherapist in Poland, and that Polish study was a proper prospective randomized trial. Like all of them, you can criticize it, perhaps too many people, perhaps too much variation in quality. Is long course and all the extra money really justifiable? I doubt it, personally. We're in Champalimaud, we're heading and have been giving single-dose treatment for low and intermediate risk prostate cancer for some time now. You get a totally different response to the radiotherapy, because you get a gush of extraordinary substances from the rapid revascularization that occurs in the time immediately following the single dose. So that's exciting. We have not changed our indications for chemoradiotherapy. We're quite different from the French in that regard. When we're not doing local excisions after radiotherapy. You've heard all about these things, and they're just exactly as Gina has recommended to us. But what we are doing is trying, and we've now got a new thing called TrueBeam, which is going to be even more accurate than VMAT was, just to rush through the progress that has taken place as we go back. The important thing, intensity modulated radiotherapy and volume modulated arc therapy, which just is a very accurate tool for delivery. It's focused radiation. With apologies to my leader and teacher in radiotherapy matters in the front row, so what we're considering nowadays is the same as radiotherapists always have. In the GTV is the actual cancer you can detect on the MR. The CTV, the next volume out, is the prophylactic irradiation you consider justifiable. And then outside that to the PTV, which is what you actually deliver, is a little bit to be on the safe side. And Oriol Pares has reduced that outer layer from down to 0.5 centimetre or less. Of course, you're inevitably going to you're going to damage some tissue, but this focused radiation, creating a radiotherapy target volume, is getting more and more like surgical radiotherapy, and I find that really exciting. The lateral nodes. I've always been a lateral node skeptic. I don't believe they have any real clinical significance or relevance unless they're actually staring at you surgically. Interestingly, Leonard Blomqvist, who's another radiologist, after Gina, the most regarded perhaps in the world by me, because he helped us up in Stockholm years ago, and he remains a friend. More than half his local recurrences some years ago, well, 10 years ago, but more than half of them were due to recognizable remnants of mesorectal tissue. So it's inadequate TME we've got to learn not to do. And Soren has shown us that they all too often are incomplete mesorectal excisions. So that, I think we had to learn to do that operation properly. I think this is an interesting workout by Lennart of how often a lateral node is really the cause of the local recurrence, which perhaps kills the patient or becomes a real clinical problem. Only 2 from nearly 1,000 he calculated. The argument persists. There's this paper recently of a wonderfully constructed Japanese study. The argument persists. The GTV, of course, will take care of them anyway if you have really high-grade imaging. It's like running your whole plan on good quality MRI is the key. If you look at that Japanese study, it's so interesting to me because all my life we've had a fight between the people who believed they were really important and those who didn't. And the Japanese have always felt they were important, but it's interesting that they deduce, and I thought, well, that's the end of the argument. If you do a prophylactic removal for nodes that are not obvious, it doesn't make any difference to the relapse-free survival. But they stated that and went on to argue that that was an argument for doing it, and I could not understand that really. A few little excitements. I've mentioned VMAT. These are the real people. The radiotherapy is just like the surgery. That Ines Santiago on the left is a very skilled Gina-trained radiologist, and Oriol Pares over on the right is a surgical radiotherapist. These sort of pictures, it just shows you motion is important in targeting radiotherapy. And Oriol has designed an intrarectal balloon with Fiduci, which the machine can follow, and he also is keen on the simultaneous integrated boost to get bigger doses to the actual tumour, raising the dose to the target. The problem is going to be long planning times for doctors and physicists if this really takes off. But I think it's exciting, and I think that in many ways it may be the most important of these things. You look there, the yellow is, if you like, the protected tissue in a VMAT plan. Yellow, what we don't want to damage, and that colour there is a TME, a TMI, a total mesorectal irradiation. We published this discussion paper in DCR about a year ago, and we'd love you to join in the debate. Essentially what we're saying is that only the mesorectal tissue with no obvious cancer in it is actually worth irradiating, and once you get outside that all-important mesorectal fascia, it's probably doubtful unless there's something radiologically apparently malignant, which will be taken care of by the GTV, as I say, why irradiate all the other tissue? And so we have there, if you like, an illustration of what I've just said. Yellow is what is specifically protected from the new kind of radiation, And you see how a TMI is much like. It will at least cover that 30% that Soren has told us bits of the rectum get left behind. I keep flashing the complete response because I must finish. But we do believe that there is an ethical duty to discuss whether a patient who is suspected of having a complete response really needs to go through either a low anterior resection, which will be by definition one after radiotherapy with a high risk of loss, or perhaps they should go into what we run in a big way, which is a surveillance program. This is the first case I ever saw. I haven't time to tell you the story about a lady from Atlanta, Georgia, who Gina helped me with. The cancer disappeared into a scar, and she said, well, if Dr. Gina Brown says there's no cancer, I don't want any operation, thank you. But sadly, as Gina said about a year later, I'm a bit worried about that bit there, and so we did a low anterior resection. At least it wasn't an abdominoperineal, and I begged the pathologist at the Marsden to find some cancer, and he couldn't. And I rang him up and said, look harder, because she'll never forgive me for doing this operation. So that's what started it all in my head. I think a PCR is at best a hollow victory. I think you should always have a sleepless night if you get back a report of one. My second opinion is almost always, when people ask me, and I have looked at it all, watch and wait a little longer. Operation for regrowth, it seems that we haven't got the data yet, and of course that will be the final bit of the argument. But our own experience is a uniformly favourable outcome. I must go faster. Angelita, bless her heart, who got and this is a lovely patient that I'm so fond of. Now, you know, the cancer had gone by the time I got to Lincoln. What are you boys whispering about, she said. And then she said, I'll talk to my God, you look at your x-rays. And there she is 10 years later because her God told her not to have the operation. And I said, well, I'm glad about your God thinking it's a good idea because he knows more about it than I do. The surveillance clinic in Champalimaud, Nuno, he is looking at these things. This is our new implementation of the ideas, talking to the patient, looking at the pictures, both mostly MRs, but also the endoscopic pictures at the actual clinic. And we have some quite exciting looking burns, as you can see, but that one over there, the one that looks all silvery, that's a complete response in the long term with a good functioning rectum, extraordinarily. Don't know how long it'll go, but I'm going to flash through this and give you a summary slide of sending a third of them straight to surgery, 2/3 worst cases. Remember, we're a tertiary referral place. Just on 100 cases when I made this slide, and the key bit is in yellow, and at least 1/3 of the bad tumours that deserve radiotherapy according to the GINA rules, no cancer, no surgery, and no stoma. At an average of about 3 and a bit years later. Of course, we've got to wait. And again, the rate at which the local regrowths occur, this was a review by Mit Datani, a very fine resident, of everything published in the world so far. That's earlier this year, so it's not quite up to date. But you see, nearly all of the ones we could detect had occurred by the end of year 3. It's very like following most of the cancers that are curable. And these are not having surgery, remember. I think the big argument is that, of course, we are identifying by spotting the good response, or the TRG3, the TRG1 is a complete response, the TRG2s, the ones and twos, we are picking out the very best cancers. So when you look for watching and waiting, you find that actually there are slightly more metastases in more than 1,000 cases that have been operated on. That's just collecting together a group. But in all of the published cases, only 7% got metastases. Remember that the overall rate is 30%. We are spotting better cancers, and they can be watched when and dealt with in the way I think that we're suggesting. That's my very last slide, because I think of all the things we're doing with focused radiation, sparing the anal canal and reducing the amount of loss may be the thing that comes to help us quickest out of all this new thinking. Thank you.
Thank you very much, Bill. There is too much to be integrated in the diagnostic and therapeutic process of colorectal cancer. There will be a lot to see in the future.